Hi everybody, welcome back to the Clean Scalpel. As you know, we've been taking a different route to our channel. Instead of going through some of the technical aspects of surgery, we're now going to focus on some of the fundamental knowledge required as you read vascular ultrasound. In continuation with our current goal, we're going to move on to venous duplex. As you know, last week was peripheral physiology, so for those of you who are still having some trouble with that concept, go back and watch that video. I think you'll find it very helpful. And I've tried to make this video equally as helpful as we review not only the concepts of venous physiology, but also a lot of ultrasound basics. So with that, let's get in motion. So as always, guys, what I really enjoy doing is just going through questions, and let's get started. So what does this show? And since we're talking about venous physiology, this is a venous study. And my question to you is, what does this picture show? Is it A, a normal study? Is it B, is it an abnormal study that reveals a DVT? Is it C, it's a normal study which shows a chronic DVT? Or D, it's an abnormal study representing someone with proximal obstruction? So let's just take a second and think about this. Okay, and for those of you who found that it was a normal study, you're in fact correct. For those of you who said, well, Dr. Schukel, why couldn't it be a normal study with a chronic DVT at this location? That's a good question, and we will get into some of the details of DVTs later on, and so I think it'll help answer that. But again, going back to understanding venous physiology, we really have to know what is normal. So this image specifically is a longitudinal view of the femoral vein. Okay, when you look at a longitudinal view, what you're seeing is that the left side of the screen represents the head, and the right side of the screen usually represents distally, or in this case, the toes. And this particular image was obtained with the patient in the supine position, which does make a difference. And what you see is you see normal venous phasicity, which is a response to respiration. And you see here a Valsalva response, okay? And these are, again, normal findings in this study and what you should see as you look at a venous duplex. You should see the normal venous phasicity with respiration and any other factors, Valsalva, compression of the leg or the thigh, you'll notice these studies. So, same concept, okay? What does this represent? Is it A, a normal study? Is it B, an abnormal study, which represents a DVT at this location? Is it C, a normal study, which represents chronic DVT at this location? Or is it someone with an abnormal study that has proximal obstruction? So I'll give you guys a little bit of time to find this answer. Yeah, and for those people that said it's an abnormal study with proximal obstruction, you're absolutely correct. So let's understand this, because clearly this is not a normal study, because we showed you a normal study previously. So what really helps make this something that represents proximal obstruction? So there are several signs of outflow obstruction that you should be familiar with as you're looking at venous ultrasound. Now, you will see that there is reverse flow in collateral branch vessels. So as we go back to the previous image, what do you notice here? Okay, well, first thing is that the blood flow, this is here blue, which means it's away from the Doppler. So the blood's moving this direction, so it's going in this. But the first thing you see that's kind of obvious on the color flow is that you see a reversal flow, which basically means blood's going from here up and then now moving in this direction. So that should give you a hint that, hey, this is not necessarily a normal finding in someone's common femoral vein. When have you seen a large collateral like this? So maybe there's something going on a little bit more proximally. Another sign is if you actually end up looking more proximally, you will see that there is, unlike a normal system where you have the artery and the vein, sometimes you'll see the artery, but you won't really see the vein. So an inability to visualize the proximal vein obviously is a very obvious sign of outflow obstruction. Finally, the one thing that really sets this apart is the fact that you have continuous flow here, okay? Now notice it's all continuous flow towards the heart. So ask yourself why that is. Well, if you do have obstruction proximally, you're always going to need the entire cardiac cycle to bring blood flow back to the heart through collaterals. So we're just going to throw out random variables. So let's say that you get a liter down in the leg a minute. Now, to get that liter back, normally during respiratory variation, you'll have some moments in a normal patient where you'll have more blood flow coming back and then less as intra-abdominal or intrathoracic pressure increases. But with the proximal obstruction, you're going to need the entire cardiac cycle to send blood flow back to the heart. And that's a good, easy way to remember the fact that someone with a proximal obstruction does have continuous flow in their veins. So let's move on. Okay? So take a look at this particular image. Okay? We see some of the respiratory variation, but I have a very specific question for you. Which direction is the blood moving? So again, this is a venous study. Which direction is the blood moving? And I'll give you guys about 5-10 seconds to figure this out. Right. So again, pretty easy for the ones that we were paying attention earlier is screen right to screen left. Now, it's screen right usually as you're looking at the monitor to screen left. So why is this? Well, there's a couple of different reasons. So it's a venous study just based on the waveforms here, number one. Number two, if you look at the color bar here, it tells you that red is towards the probe and blue is away from the probe. And the probe, you can imagine, is up here. So as you're going away, the vector is going to be in this direction, which means screen right to screen left. And if you're paying attention a little bit earlier, when you're looking at a longitudinal view of any structure, the left side of the screen usually represents proximally, and the right side of the screen represents distally. And as you know, this picture looks very similar to the other pictures we've been looking at. It is the common femoral vein, and so blood flow should be going from distally to proximally. So a lot of different things that tell you or give away this answer. So let's make it a little bit more challenging, okay? In this picture, which way is the blood flow moving? This is a different picture than the previous one, but which way is the blood flow moving? Right, and so for those of you who picked screen right to left, again, you're right. It's not a trick question, but a lot of the times when you focus solely on the color bar, you will get a little confused when you find a picture without color flow in the spectrum. Now, there's many different things to kind of wrap your head around as you look at this picture, but let's just simply look at the sample volume. So it's right here, and this is the sample volume, and this is the waveform represented by that sample volume. What you will see is that on the color bar, the negative indicator represents blood flow moving away from the probe. And in this situation, it would represent blood flow from the right to the left. Now, then as you look at the Doppler waveform, you see that most of the blood flow is in fact negative, especially in the velocities. So you can deduce that yes, in fact, if the settings were adjusted a little bit better, that you would indeed see blue coloration in this vessel. And so this is, again, really, really important to know. And you always have to look at the other things that are present on these images to get a better understanding of how to read the venous physiology. So again, you see some of the respiratory stuff, but now I have another question for you. Okay? So what does this represent? And this arrow points to this blip right here, okay? So is this calf compression? Is this a venous emboli? Is this a Valsalva maneuver? Or is this someone having thigh compression? So think about the things we've talked about a little earlier, and this is a little bit of a new concept. So what does that blip really represent? Yeah, and so for those of you who figured out it was a Valsalva maneuver, you're 100% correct. And so let's really break this down so we can better understand what's going on. Now, when you Valsalva, what are you doing? And if you're sitting in front of me right now, do one yourself. You're increasing your intrathoracic volume by taking in a deep breath. You're squeezing down on your abdominal musculature. And what's that doing to the intra-abdominal pressure? It's increasing it. Well, with an increased intra-abdominal pressure, what is that going to do to the venous return in the legs? It's going to decrease it. Exactly. So what you're seeing here is as the Valsalva occurs, you actually see blood flow very shortly in the opposite direction. So what does that mean? So blood flow is normally moving towards from right to left, but for that brief moment, what happens? Well, you increase the intra-abdominal pressure and blood flow wants to go backwards. And does it? No. And we will talk about why that is in a second, but this is that representation. This represents the Valsalva maneuver. Now, let's differentiate this from some of the other answers that were presented. So this is an image of the great saphenous vein on the right side. Now, when you augment things in the leg, okay, so augmentation of the calf, what happens to the blood flow? As you squeeze distally, again, right to left, proximal, distal, blood flow is going to move from screen right to screen left, okay? And how is that represented? Well, look, you see it here. You see a burst, increased velocity going in the negative direction, in which this case, if the color bar was here, blue would be away from the probe. And that's what you see right here. But what is really happening? Well, the valves, which as you know are one-way valves, are opening up and allows the blood flow to go back to the heart. Now, but in that instance at the end, you do have a little bit of recoil, which you see blood flow going back in the opposite direction. These valves shut, and the blood flow in the vein is temporarily stopped. So very interesting concept that you can actually see as you're looking at these venous duplexes. Now, as you look at pathology, these concepts become very, very obvious. So it's again the left great saphenous vein, and this represents reflux, which is very, very obvious to the people who have seen it before. But for those of you who have not seen it, this study is usually done with the patient in some form of standing position or in a dependent position where they have the portion of the legs a little bit lower than their heart. And what do you think happens here? And we've seen this similar pattern before. Yeah, someone's actually squeezed their calf. So you see blood flow going towards the heart. And then as that recoil would normally happen and the valves would shut, with incompetent valves, what do you see? You see a prolonged period where the blood is moving in the opposite direction. And normally this is what represents reflux. And we see the representation of that, blood flow moving in the wrong direction. And for the people that know, 4 seconds is essentially definitive. And normally we're only looking at about half a second to a second to note a significant reflux. Okay, so again, a lot of concepts coming into play. The longitudinal view of a vessel, and they tell you what the vessel is. So you know the heart's on the left side, the feet are on the right side. You're paying attention to the color bar here. Red is towards the probe, blue is away from the probe. And then as you correlate that with the things we've seen down in the Doppler waveform, it really makes sense. It really tells you exactly what's going on inside the vessel. And this is what I find so beautiful about looking at ultrasound. It really is a great tool to look at the physiology of what's going on inside a blood vessel. Now, again, testing a little bit more of the basic concepts. Which groin are we looking at? Very simple question. Which groin are we looking at? And I'll help you a little bit more. This picture on the left-hand side here represents a non-compressed view. And the picture on the right side represents a compressed view. So take a second. Are we looking at the right groin or are we looking at the left groin? Yeah, and so don't confuse yourself too much. We are indeed looking at the left groin. Now, this covers a lot of concepts, though simple, but can sometimes confuse people. The first concept is the orientation of the artery and vein from the right and left groin. So, as you recall from anatomy, the vein is always medial and the artery is a little bit lateral to the vein. That's the first thing. The second thing is when you have the ultrasound in a transverse view in any part of the body, the left side of the screen always represents the patient's right side. So for those of you who've heard this for the first time, I'll repeat it. The left side of the screen in a transverse view represents the patient's right side. So with that noted, this is why we're looking at the left groin, because the vein, which when you compress it, and it does not have a DVT, disappears, and what you're left is with the artery right here. And this can only be possible if you're looking at the left groin. Now, what if we're looking at the right groin? Well, the Mickey Mouse ears would be on the right side and the artery would be over here. So let's build upon this concept. What does this study represent? Okay, is this a normal study? Is this an abnormal study with a DVT? Is this a normal study with a patient with a chronic DVT? Is this an abnormal study representing someone with proximal obstruction? Take a second to think about this. So again, pretty obvious. For the people that know, you're looking at the left groin for the very same reasons. The artery doesn't compress as much as the vein here. And in fact, this does represent an abnormal study with a DVT. The normal study with the chronic DVT wouldn't really make sense here again. But let's talk about that in the next slide here. But all you can really tell from this particular image is that the study is not normal because the vein would in fact compress totally. And because of the lack of compression, these are one of the findings you get with a deep vein thrombosis. So these are certain characteristics that we talk about and how you differentiate between acute and chronic. And many times it's very, very difficult to find out if it is an acute or chronic, and usually the history of the patient helps you determine this. There can be some age indeterminate DVTs, and I think, again, talking to the patient, finding out the onset of symptoms, and as well as looking at some of these findings does help you differentiate between the two. But I've left off some of the concepts of what they represent. So an anechoic or hypoechoic thrombus, that's homogeneous, poorly attached or floating with smooth borders. And usually if the vein, as you look at it under B mode, has an increased vein diameter with very, very small collaterals, usually represents an acute DVT. Now, let's just think about this for a second. Does all of this make sense? With a fresh clot, and if anyone's seen it ex vivo when you're doing a thrombectomy, you know that it's very soft. It's pretty much homogeneous because there's not a lot of other scarring that's occurred into it, which is why you can pull it out. And the fact that it's poorly attached, the borders are in fact smooth. And because it is a fresh thrombus, usually the vein itself does dilate because there is increased volume in that particular location. Why are the collaterals small? Well, because it's acute, the collaterals haven't had a chance to develop to augment some of the blood flow leaving the leg. So this is why all this makes sense. And it's for the same reasons why the other findings you see with the chronic DVT make sense. It's brightly echogenic. Why? Because it's been there for a while. There's a chance for inflammatory cells to come in and play a role in scarring some of it down, which is why you also get a heterogeneous appearance of the clot. It is well attached because of the inflammation. The irregular borders can represent several things, sometimes recanalization. Why are the veins small and contracted? Well, when blood flow is not being used in that one location, the vein does over time contract. And as a result, you will see large collaterals that have developed to augment the blood flow leaving the body. So these are things that, as you look at the patient's history and you look at multiple pictures of these veins, you will start getting a feel of, yes, this is an acute thrombus, or no, this appears to be much more chronic in nature. So let's look at a patient example here. So you have a 74-year-old female patient with an ulcer, and your amazing tech does an ultrasound and finds that there is a distal calf perforator. And when you look inside the vein in that perforator, you see there's some pulsatility in the flow. Okay, but let's, as she continues to do her scan, let's look through the rest of this. So in fact, there's pulsatile flow in the vein, proximally in the right popliteal. And in fact, even on the right side, the side of the ulcer, there's some pulsatility in the vein. Now here's a key thing in this patient. You also have pulsatile flow in the left side. So let's look at that, okay? So what does this represent? You have an abnormal study with a distal AV fistula. Is it B, an abnormal study with the patient with a DVT? Is it an abnormal study with the patient with congestive heart failure? Or is this an abnormal study with the patient with proximal obstruction? Take a second to think about this. And most of you I know are probably between two answers because we've discussed the other two. So really use your thinking caps here. And this one's a little bit tricky. Yeah, so for those people that said it was in fact abnormal study, you're correct. So way to identify that, number one. And number two, it is represent a patient with congestive heart failure. So a lot of you guys are thinking, well, why not distal AVF? And number one, it wouldn't be bilateral and wouldn't be so symmetric as a clinical answer to this question. But let's look at the actual waveforms. So specifically, when you think about congestive heart failure, if you imagine that the venous return to the heart is essentially a cylinder, a column of volume or blood, in congestive heart failure, your volume is usually increased, and therefore the veins expand and usually gets to its maximum capacity. As you guys remember some of these curves, that the venous volume is also up, and so is the pressure, okay? And it's with this increase in volume and pressure that when you don't really have room for the vein to expand anymore, every heartbeat is actually transmitted back down into waveform into the legs. So isn't that something beautiful you see? You actually see pulsatility of the vein in the right lower extremity, left upper lower extremity, and if you laid the patient supine, you could probably see it in the other extremities as well. So again, this says so much about the physiology, and again, you can see that in a simple venous ultrasound. So let's understand this for a second. Let's assume that this was in fact a arterial venous fistula, okay? Well, what would happen if you had a distal fistula on this side? Well, during systole, what would happen? You would have blood move forward in the vein in this direction. If it's distal, during systole, you'd get a jet of blood into the vein, which would force the blood to move from distal to proximal, okay? So let's break down this image then. So most of the blood flow here you can see is negative, which if you look at the color bar, negative represents blood flow moving away from the probe, and that's from a screen right to screen left. During systole, you would expect there to be a jet more in the negative direction. But in fact, what you see is just the opposite. During systole, you see some blood flow moving in the opposite direction. So how is that really possible? Well, this is essentially the transmitted wave from the heart in a patient that clearly has congestive heart failure or sudden volume overload. So this is how you can differentiate the two. But again, a very cool picture. The increased pulsatility does represent congestive heart failure here. I hope this is it's been a very simple learning tool, but I hope you guys now understand a lot of concepts about the laterality, how you look at longitudinal versus transverse view of the ultrasound, really understanding the color bar and how the blood flow is moving, and then specifically looking at the waveform to see what is normal, what's not normal. And guys, again, with that, I appreciate your time. It's always a pleasure. If you have any questions specifically about this or our previous talks, write them in the comments below. Otherwise, we'll try to get to you next week or the week after with some information on reading a carotid ultrasound. Okay, guys, thank you very much. Have a good one.